Hello everyone. Today we are going to do anesthesia for laparoscopic cholecystectomy. At first we are trying to establish a secure channel, and you are seeing how difficult to find a vein in the dorsum of the hand of this patient. As she is a female patient, she has very narrow vein in her periphery, so we are trying to find it out. We are trying to tapping her dorsum, but not perfectly seeing any vein which can be cannulated. Our respected doctors are trying to establish a secure channel and seeing any other options in the dorsum of the hand, and maybe we are seeing some vein which can be cannulated, and we are trying to cannulate it with 20G needle, 20G cannula, brief round. We are seeing a vein, and it is perfectly flash of blood, and it is perfectly cannulated. And then we are secure it with a micropore tap, and the tap is given, and some person who is holding the hand causing the blockage of the venous drainage to increase the tortuosity of the vein, which is performed from the beginning of the cannulation process. And a venous line is established, saline set is connected to the hub, and then we are giving 2% lidocaine for pain relief of the patient, as she is complaining some pain in her dorsum of the hand at the cannulation site. And we are giving some lidocaine and stop the chamber. And now we are giving the anesthetic drugs, and at first we are giving the Amistate, which is actually ondansetron, 8 milligram, for reduction of the experience of nausea and vomiting. And we have started the pre-oxygenation procedure, and now we are giving the fentanyl, which is a ultra short acting opioid for the pain relief during the stress response of now we are seeing the hemodynamics in the monitor. And at last we give the propofol, which is the king of all anesthetic agents. It's a very much highly capable, highly effective IV anesthetic, and we are giving it to the patient for the sedation or for her sleep actually. And it has been given. Now we are giving the depolarizing agent, neuromuscular blocking agent, which is suxamethonium, and we are seeing this. And suction has been given. After giving the suxamethonium, we can see a fasciculation in her hand. We are waiting for the fasciculation. We are seeing the channel, and now we are waiting for the fasciculation. And the fasciculation, we are waiting for the fasciculation, and we are seeing the fasciculation started, but very mildly fasciculation has been started, very mildly, and now fasciculation has been stopped. So we are good to go for the intubation, and the intubation process is done. One of the assistants opens the mouth, and the laryngoscope is introduced. Then in the tracheal tube, and the anesthesia instructed the assistant to hold the trachea to a side for a birth maneuver, and then the pilot tube has been inflated for fixation of the tube, fixation of the endotracheal tube, securing the endotracheal tube to remain inside the glottis. And we are seeing the monitor, which is given the data after induction and intubation, and we are seeing there is no highly increase of blood pressure or heart rate, and now we are seeing some rise of blood pressure and heart rate after intubation reflex, but almost it has been perfectly controlled with a very strong intubation. Now we started the isoflurane and adjust the oxygen and nitrous gas for the carrier gas.
nitrous oxygen
And after
ratio.
that we are going to start our ventilator,
Starting the
and the below is in the low, so we flush some oxygen to fill the below, and we are seeing the ETCO2, and it's confirmed that the critical tube is in the perfect place. Then we are giving the long-acting atracurium. It is a non-depolarizing muscle relaxant, and it's a long-acting muscle relaxant. And we are seeing that surgeons are draping has been completed by the surgeons. Now we are saying the ventilator setup, and we have been saying that monitors in the monitor of the hemodynamics for the patient, the blood pressure has been increased somehow higher, 174 by 110. So we have to manipulate the situation by the ventilator setup or anything. Yes, we are going to increase the PEEP to reduce the blood pressure, and we know the PEEP can reduce the blood pressure, and we increase the isoflurane to some extent to reduce the blood pressure. Actually, to quickly fill the lung with the isoflurane, we are trying to increase it. Saturation 100%, and perfectly we are seeing that blood pressure is reduced to 131 by
set the interval for 3 minutes
for our situation. We are expecting this type of results for the
concentration of 1 mg
operation.
So we are reducing
And now we are going to see
isoflurane
that we reduce the isoflurane to its mag value, to close to its mag value 1.3 to 1.5.
And we are saying
the tidal volume expiratory is low, so we increase the expiratory time. That means we reduce the IE ratio, that 1:3. Maybe to increase the expiratory tidal
we
volume.
increase the expiratory phase of the ventilator, so you can see the increase of expiratory tidal volume.
You can see the incremental increase of expiratory tidal volume, 426 ml, 427 ml, slightly increase from the previous. And now we are giving paracetamol, acetaminophen, which is branded as Reset 1 gram. It is for post-operative pain killing. As we know, it needs some time to activate in the body. Now we are seeing the gas machine, which provides the insufflation gas to the intra-abdominally, which will establish the pneumoperitoneum. Now we are seeing the intra-abdominal pressure fluctuating from 12 to 14 and 15 millimeter of mercury, and we expect to have this type of intra-abdominal pressure throughout the operation. So the number should not be changed a lot, but after having the pressure of 115 millimeter mercury in the intra-abdominal, we can see there's some change in blood pressure and heart rate. And this is it. We are seeing the heart rate reduced to 60 and blood pressure is 110 by 65. This is why, because 10 to 15 is a very high pressure zone in abdominal pressure, causes the reduction of causes the collapse of the or compression of the inferior vena cava, and which reduce the venous return to the right atrium, which eventually reduce the blood pressure in our
settings.
Now we also see the monitor. This is what to do throughout the monitor to stabilize the patient hemodynamically, to regularly check, regularly rhythmically change or check the monitors and intra-abdominal pressures, ventilators, oxygen saturation, to make the patient to be secure in our hand, in the hand of surgeon. We are seeing the intra-abdominal pressure fluctuating between 11 to 14 millimeter of mercury. And we are expecting to have this type of intra-abdominal pressure throughout the operation, but we are seeing that the reduction of blood pressure, heavy reduction of blood pressure here, so we decrease the PEEP to off situation and trying to increase the blood pressure right now. And I see the ETCO is reduced to 27 millimeter of mercury, so we also reduce the respiratory rate. We reduce the respiratory rate to 11. which will
the
eventually increase the ETCO2. We all know that.
Now we have to check whether there is reduction or
And there is ventilator
increase
is working.
of,
We're seeing the expiratory diaphragm reaches 471
and we are seeing there is no change in
ml, and we are
pressure,
seeing
which
the
is
intraabdominal pressure
2.2
fluctuating between 11 to 14
Maybe
mm of mercury. There is slight
still low
no. We are seeing the blood pressure is remain at that period. The timeline of 3-minute interval of an IBP is ticking ahead, and maybe we are getting it within some seconds, few seconds.
reducing the respiratory rate, the increase of
And the heart rate is reduced to 56, but this is not a big concern for us, because if the perfusion is reduced for a longer period of time, it may be a problem for the patient, or if the patient is compromised in any organ system, this may be problematic. But she is a very young patient, and at the middle age of 30 to 40, so we are not expecting that slight reduce or very short time reduction of hemodynamics, reduction of blood pressure will affect the perfusion or causes any untoward event.
restricting more than that.
Yeah, there is slight increase of systolic pressure, and mean pressure is actually 53, so we reduce the isoflurane to some extent 1.5 to 1%.
And another plan is to increase the volume status of the patient. Maybe
Okay, we
she
are
has
observing water
been,
very carefully.
starved for 6 to 8 hours.
Actually,
So
total
there may be
period of
fluid deficit for her.
system is less than 30 minutes, so
we
it's
are
a very
giving
short
the,
period of very short period of operation. We are seeing that the paracetamol has been given, so we disconnect the saline set from the Napa bottle, so from the
we are going
bottle of paracetamol, and introduce it in the saline bag of Hartmann saline bag, and we are giving a bolus saline for increasing the blood pressure, as we may think that she has been starving for 6 to 8 hours, so there is some fluid deficit. There must have some fluid deficit, and we are trying to recover it as possible, as quickly as possible, to make the blood pressure in a comfortable way for us. And there's also a benefit of reduction of blood pressure during the laparoscopy is that there is a perfectly clear or a neat and clean operative field during the resection of the calloid triangle, which is necessary or which is actually good for the surgeons. When the blood pressure is rises, the venous pressure or capillary pressure also rises, and surgeons have untoward bleeding inside the calloid triangle, and they have to face some difficulties in securing the calloid triangle, or to find out the structure such as CVD or any other structure, or there is some veins and arteries. They may get confused when the high blood pressure and the operating field getting dirty or extremely red.
And these are what you see the monitor. Okay, there is some sort of another reduction. So we are seeing the high intra-abdominal pressure.
Okay,
so
the blood pressure is also in the same situation. So we are confirmed that the blood pressure reduction due to the high intra-abdominal pressure. So we are giving the glycopyrrolate, which is slightly increase the heart rate, not much as atropine. So we can have some incremental increase of blood pressure. And we are seeing after giving the glycopyrrolate, we are seeing the blood pressure is 89/55, so there's an small increase of blood pressure, and heart rate also increases to 58, 100%, and we are expecting that it will increase gradually in some moment. We are not using atropine in this case, but maybe we can use atropine also when there is very resistance, when the patient is resistant to glycopyrrolate. But in this case, the patient is not resistant to glycopyrrolate, and blood pressure is increases as heart rate is increases. There is now blood pressure is 95 84 by 58 and heart rate is 81 right now, and it's slightly increases to 85. So we're achieving our goals very quickly, but not a overt response like atropine. So we choose here glycopyrrolate. But you can use ephedrine, you can use atropine as you like to increase the blood pressure. Yes, we are seeing the expected blood pressure of 140 by 90, heart rate of 97, which is moderately effective, and already the time has been passed. Surgeon has secured the calot triangle. Now they are going to dissect the gallbladder from the liver bed. So most of the important work has been done. After the dissecting the gallbladder from the liver bed, they will see if there's any bleeding inside the liver bed, outside the liver bed. Then they will come out with the specimen of the gallbladder, and we are seeing that there's no bleeding inside the abdomen and at the liver bed, and we are getting the visual of the perfectly okay hemodynamics here. Blood pressure 140 by 90, heart rate 98, situation 100. So very perfect situation. When they brought out the specimen of gallbladder, they will close all the ports, and after closing the ports, we'll start our reversal protocol for this patient, as it's a very little gallbladder, so it's not difficult to bring it out. The operation is not more than 30 minutes, so it will be easy for us to reverse. Actually, we are not giving much more of long-acting anesthetic, long-acting neuromuscular agent for this patient. As we know, it will be a very small duration operation. Total duration of operation till now is not more than 30 minutes, but we are giving a video of 16 minutes. Okay, enough time for seeing the specimen. So when the surgeon is starting their closure of the port, we reduce the total flow and convert it into the low flow anesthesia, and we close and stop the isoflurane. And the benefit of low flow anesthesia that it can be reuse of anesthetic agent and nitrous in the circuit for the rest of the time, and we can save some money for the hospital and for the patient. And we are seeing and we are reducing the heart rate to increase the ETCO2. As we know, if the ETCO2 is reduced, the patient will not show some ETCO4 during his or her reversal. Yeah, we are seeing the pressure 137 by 90, which is perfectly okay for us. Make inspiratory report. We are seeing the hemodynamics already is very perfect scenario for reversal, and we are ready for reversal. Maybe we started the oropharyngeal suction right now to check out any secretion inside the patient, and we stop the nitrous and increase oxygen to wash out all the carrier gases, nitrous, to give the patient more oxygen filled in her lung. And we are seeing that patient is breathing, which has been seen by ETCO2 graph. We are giving the and we are starting the oropharyngeal suction. There is some secretion inside her mouth, and which is expected. And after cleaning of this after cleaning with the secretion in the suction, we are going to give the reverse. The reverse will be prepared with 7 neostigmine ampoule, each of them is 0.5 milligram and 2 glycopyrrolate. And we are going to give the patient the reversal. We give the total reversal. We are seeing the patient is patient is breathing, and she is breathing 309 ml of inspiratory volume, tidal volume. Now we are going to extubate the patient. It is very much fortified to prevent any disconnection during the operation. Okay. After removing all these micropores. We are going to extubate the patient from her glottis. And we are seeing patient is biting. There's some barking reflex. Yes, we pulled off all the gases, all the air from the pilot tube, by the pilot tube. And patient is some sort of vegetation here, and there is some orofacial suction also. And other orofacial is quite alert right now, and she is showing her tongue. And we are perfectly okay. We think we are very close to our objective. And thank you everyone.